So in this series, actually, I'll be keeping all previous years FMG plus NEET PG and INICT image-based questions, and my effort will be to just highlight the things so that you can identify the image as such, right? So what I'll be trying to do, I'll try to simplify the things, and I'll be highlighting the key points in a given image, and with the hope that it will help you in solving the image based questions in the exam proper, right? So I will not be going in detailed theory as such. My special focus will be on to highlight all those points which will help you in understanding what actually this image is, right? So how to identify a given image, that I'll try to simplify, and of course if we have a clinical case history, that I'll also try to decode, right? So starting with the very first question, and the question is about the treatment of the given condition. Okay, so whenever you have this kind of question, now the very first priority is to make a diagnosis. So the very first thing is you have to reach up to the diagnosis, that what actually is being shown in the image, and then only you can go for the treatment part. Okay, so yes, Shanawaz bhai, you are absolutely right. Now this is a classical picture of herpes zoster. Clear? So yes, you can write, you can say it shingles. Clear? So this is a classical picture of herpes zoster, and we can give antivirals like acyclovir. Now for someone who is a beginner, now how to identify that yes, this is a image of shingles or herpes zoster. So what you need to do, firstly you look both the side. So this is you say one side. Okay, so if I say one side, this is second side. So if we see here, we can easily see that the lesion is present only on one side. Okay, so it is not present on the other side. So the key point, if I say, the very first key point is unilateral. Clear? It is only on the one side, right? Very good, Shanwaz, very good. So it is unilateral, that is, it means it is one-sided, right? Now secondly, just look at the appearance. What you can see, there are red areas. So actually what this actually is, there is a base of erythema on which we have grouped vesicles. So there are grouped vesicles like this. Okay, and these are on an erythematous base. So the classical lesion is grouped vesicles. Now vesicles are clear fluid containing skin lesions less than 1 centimeter in size. Okay, so grouped vesicles, and below that we can see all redness. So we will write on erythematous base, right? Erythematous means red. Clear? So that's why we are seeing a lot of redness here, and if we look properly, we will see multiple clear fluid containing lesions less than 1 centimeter in size, and these are in groups. So it is grouped vesicle. Then third thing which you need to remember here, these lesions lie along a particular dermatome. Clear? So this is also in the classical description. So the lesions are present along one particular dermatome, right? So these are three key points which are necessary to identify or to label a given condition as herpes zoster. Yes, of course, those who have seen plenty of images, they can just look at the image, they can simply say like that. But for a beginner or someone who want to have a theoretical association for diagnosing, please remember these 3 points. And clinically, this is extremely painful condition, right? So at times in question statement you can have this painful word as well. So this all suggests the possibility of herpes infection, especially herpes zoster here, right? So this is herpes zoster. Now we move on to another condition, and here truck driver developed painless ulcer over genitalia. After some time he developed lesions like this. So now what is this? Now firstly it is written as truck driver, right? So occupation is given. Very good, very good, Shanwaz bhai. This is syphilis. And most important thing is painless ulcer, right? So painless genital ulcer. Clear? So truck driver might be involved in some sexual activity somewhere without taking proper precautions. So therefore it is cleanly written here. So this can go for STD. Now painless, the moment you find the word painless, it with ulcer, with genital ulcer, it goes in favor of diagnosis of syphilis, right? And this is actually primary stage. The ulcer in the genitalia, which is painless, that is primary stage. Now after some time the patient will enter into secondary stage. Clear? And the classic description of secondary stage of syphilis is symmetric rashes, okay, and classically involving the palms and soles. So this is, in this picture you can see these are all rashes, okay? So these spots are all rashes, and these are present in both the palms, and it looks like similar in configuration, and therefore we are using the word symmetric, almost symmetric. So this is a case of secondary syphilis. Fine. In primary syphilis you have to remember painless genital ulcer. In secondary syphilis the patient will have rashes. Clear? So this is secondary syphilis. Then moving on to another question, and again this is a image based question, and simply you have to answer what actually this is. I think this is one of common conditions which we see in India, and it is not that difficult to diagnose it. So most of you will obviously answer it correctly. You will say leprosy. But again there is a spectrum of leprosy starting from tuberculoid going till through the borderline stage going to lepromatous. Clear? So yes, Shanawaz bhai, the answer is leprosy, but I want you to answer more perfectly. This is lepromatous leprosy, okay? So this one is lepromatous leprosy, because in leprosy we have 5, 1, 2, then this is borderline tuberculoid here, then borderline, then borderline lepromatous, and finally lepromatous leprosy, okay? So this is lepromatous leprosy, and very easy to identify. You can see the classical leonine facies, okay? So if you write key points here, leonine facies, okay, we can see nodularity of skin, right? So you can see here thickening, nodularity, thickened nodular skin, right? Apart from that, you can see loss of eyebrows, that is known as madarosis. Then there can be collapse of nasal bridge, that is saddle nose, right? So this is lepromatous leprosy. Leprosy is perfect, but I want you to remember even more exact answer, so that there is no very good Shanwaz bhai, nerve involvement. So there is no chance of any mistake in exam. So this is lepromatous leprosy, and in exam you should know two things: what is lepromatous and at least what is tuberculoid. So this is a classical image of lepromatous leprosy, whereas in tuberculoid we will have very less skin lesion, and that presents with loss of sensation, right? So in tuberculoid there is a anesthetic patch. There will be a very good. So there will be less number of skin lesions. In lepromatous, the number of skin lesions are many. In tuberculoid leprosy, there is formation of granuloma in the skin as well as in the nerve, so that leads to anesthesia, and therefore we are having anesthetic patches. In lepromatous, there is no anesthetic patches as such, but yes, later on there can be involvement of peripheral nerves that might lead to anesthesia. Okay, so that is a delayed presentation of lepromatous, but this is especially in patches. If you have given an image of a leprosy patient with a single skin lesion, and if it is characteristically written that there is loss of sensation, straight away you have to mark it as tuberculoid leprosy, right? And leonine facies lepromatous leprosy. Okay, so I'll be excluding other description because that will take a lot of time, and I'm just focusing on the images only and the key points which will help you in identifying the image if you have some in exam, right? Now, management of such a condition. Now again, the first thing is you have to make a diagnosis, then only you can jump on to the answer, right? So management of such a condition here. Anyone, can you identify what is this condition here? You can see so much of crust formation. Any idea what is this? This is a form of scabies. This is a form of scabies, and that is known as crusted scabies, also known as Norwegian scabies. Now, why we talk about it so much? Because what happens in this condition, pruritus is absent. Patient will not itch, and if the patient will not itch, there is no dislodgement of mite, that is Sarcoptes scabiei. I think everyone must be knowing this. So this is Sarcoptes scabiei. So what happens? The mite, they are residing inside these crust. So they are residing here, and therefore these mites are present in very large number, and therefore the patient is highly infectious. Clear? So a patient of crusted scabies or Norwegian scabies is highly infectious. Yes, we need to give 5% permethrin, but we need to add oral ivermectin as well. Clear? So it is a combination therapy here for crusted scabies or Norwegian scabies. Shanwaz bhai, would it had been a simple scabies case, definitely we will go for 5% permethrin or BHC topical lotions. But for crusted, please add oral ivermectin as well, right? So this is crusted scabies. Now, what is the treatment of this condition? So again, the very first thing is you have to make a diagnosis, then you can talk about the treatment. So here, this condition is actually, if you see, these are all body louse. So these are all body louse here, and this condition is Vagabond's disease. Clear? So this is Vagabond's disease, which is caused by body louse. Fine. So this is Vagabond's disease. Now what happens? It is seen in patients who are now what is the word vagabond means? Any idea? Vagabond mean the person who are homeless or shelterless, right? So these homeless people, they don't bath for many days. Clear? So what happens? They get this infestation by body louse, and this body louse actually is found on clothes, especially seams, right? So if we want to treat such a case, we don't have to treat the patient, we have to treat the clothes. So wash the clothes in warm water, or you can say boiling water, plus iron them, then dry in sunlight. Clear? So this is one very unique condition where we are not treating the patient, we are treating the clothes actually. So very interesting. So this is Vagabond's disease caused by body louse, and especially seen in persons who are homeless, shelterless, or you can say even some psychiatric patient who don't take care of their hygiene of the body. So that will cause Vagabond's disease. Now what is this instrument here shown in the image? Any idea what is this instrument? This is laryngeal mask airway. Okay, so this is laryngeal mask airway, and the very first thing is, of course, you have to identify it. Once you identify it, then only you can talk about its use. Very good, Chaitanya, very good, Shanwa. This is laryngeal mask airway. So now this is used as an alternative to intubation, right? Because we know that for intubation we use endotracheal tubes and all. So whenever we feel that intubation will be difficult, right? So if it is difficult or we cannot do it properly, then in such cases, rather than going for intubation, we use laryngeal mask airway, right? So laryngeal mask airway is an alternative to intubation. Clear? So this is laryngeal mask airway. Then next question, what you can see in the X-ray. Now this is a pretty simple X-ray, and I think most of you can answer it very easily, right? So if I just draw the outline of the heart, you will see something like this. So I think most of you can answer it. Yes, this is boot-shaped heart, very easy to identify, and this is very good, Shanawaz, boot-shaped heart, and boot-shaped heart is seen in Tetralogy of fallot. Yes, Okay, so this is tetralogy of fallot. Now I won't be going in for components of tetralogy of fallot. So for the time being, we'll stick to this chest appearance. So this is quite easy, right? So boot shaped heart. Please don't do any sort of mistake in this. Then look at another X-ray and what we can find here. Now, if you look clearly, even the arrows are there, you can see certain lines like this. Okay. Any idea what is this? Now, this is the base of lung actually. Okay, so this area is the base of lung. So this is, you can say, base of lung. So these are actually curly B lines, right? And you can remember the word B with the base of lung. Clear? So these are curly B lines at the base of lung, and these suggest pulmonary edema. And pulmonary edema is secondary to left ventricular failure. Okay, so these are curly B lines which are secondary to which are seen in pulmonary edema secondary to left ventricular failure. Okay, so remember B for curly B and B for base. Okay, so curly B lines. Now what you can see in this X-ray, question number 9, you can see opacity like this. Very good, Shanawaz bhai, very good. So see, this is the normal area. This is the normal side, of course, the left side. And what we are seeing here, now this part is related to ribs, and this is of course the diaphragm. So for ribs we use the word costo, and for diaphragm we use the word, you can write phrenic or you can write diaphragm, and this area is actually the rhesus. Okay, so this part is the rhesus. So this area is known as costodiaphragmatic rhesus. Now on the normal side we should see it as a black, it should have a black impression, right? But if you look on the affected side, this is of course the affected side, right? So this is the affected side, and on the affected side you can see it is not black as compared to this side. So there is some whiteness, and for whiteness what we use the word? We use the word opacity. Opacity is whiteness on X-ray. Clear? So when I am using the word opacity, here it is a wedge shaped opacity. This is a wedge shaped opacity. Now wedge means a slice of pizza, you can remember like that. So this is wedge. So it means a wedge has been inserted something like this. So a slice of pizza is somewhere here, right? So therefore it has become all white here. So this is the classical Hampton's hump. Clear? So this is the Hampton's hump, and where we find the, yes, costophrenic angle, you can say, Shanwaz bhai, right? So Hampton's hump, this is found in pulmonary embolism. Clear? So this is pulmonary embolism. Now why this is not pleural effusion? Because in pleural effusion, here you are seeing that this is the upper border of opacity. In pleural effusion, usually we have this kind of upper border of opacity, right? So it is concave upward. Here it is concave downward, right? So this is pleural effusion. And yes, both will present as radio opaque impression. Very right, Chaitanya. It will be radio opaque, but the upper surface is different. So this is effusion, upper convexity, and this is pulmonary embolism with the convexity downward. Clear? So this is how you have to differentiate. Both will present with radio opacity, so at times students might be confused. Very good. So this is Hampton's hump with the convexity upward or concavity downward, and that is pulmonary embolism, right? Maybe in some more sessions I'll keep pleural effusion definitely, and then I think your doubt will be removed, at least till the exam. Now this is a very easy CT scan. I think most of you can answer the moment you look at the picture here. So what you are seeing, you will be seeing something like this, and right, so you will be seeing something like this in this image, right? So this is the classical. Very good. So this is the classical signet ring sign, and the moment you find this appearance, you can straight away jump to the answer as bronchiectasis, right? So this is of course bronchiectasis, right? So very easy to identify, signet ring sign, bronchiectasis. Okay, so for today's session I have kept just 10 questions because I have some other work to do. So but just to make sure that at least we are into this academic process, so I have kept a less number of questions, and I'll try to make sure that at least we have few questions on daily basis, right? So I'll try for that. So enough for this session. Thanks for your valuable time. Keep on studying. See you tomorrow. Bye bye. God bless.